Welcome, everyone. I'm Dr. Lisa Radasta, and I have with me the rock stars of behavior. And we're going to talk about the Practical Behavior Forum, which is June 5th this year in Minneapolis. It is the coolest behavior conference because we've got veterinary behaviorists that are talking to you for 20 minutes only and giving you exactly the essence of how they practice and what you need to know in order to implement those strategies the very next day in practice. So let's go around and see who our rock stars are. Dr. Pike, will you please introduce yourself?
Sure. Thanks, Lisa. Dr. Amy Pike. I'm a board certified veterinary behaviorist, like my amazing colleagues here, out of the Washington, D.C., Northern Virginia area. And I'm owner of the Animal Behavior Wellness Center and also co-host of our podcast with my lovely business partner, Amy Learn, The Behavior Buzz.
With extra Z's because
Extra Z's.
while we're talking. I love it. And Dr. Christensen, my friend, introduce yourself.
Hello, my name is Dr. Christensen, but that's way too long, so I just go by Dr. C. And I am the CMO at Behavior Vets. We see cases in New York, New Jersey, and Colorado, and do a bunch of continuing ed. So I'm excited to be here. I love to do 20 minutes is going to be tough for me, but otherwise I would say I'd love to speak to people about behavior. 20 minutes, I don't know.
Chris, tell me about yourself for those people who live under a rock and do not know who you are.
So hi, I'm Dr. Chris Pockel, and the owner and lead clinician at the Animal Behavior Clinic here in Portland, Oregon. I'm also co-owner of Instinct Dog Behavior and Training Portland, which is a facility-based, lovely growing business here in Portland where we do positive reinforcement, board and train, as well as private coaching and a variety of other training services in the Portland market.
One of your trainers, Taylor, is working with my patient who transplanted from Florida to Portland, and we'll be turning over care to you, Chris, at some point in the future. Megan, my resident maid, tell us about yourself.
Hello. So Megan Heron, and I am in good old Buckeye country in Columbus, Ohio. And I am currently Senior Director of Behavioral Medicine Research, Education, and Outreach, quite a mouthful, at an organization called Gigi's. We are dedicated to improving the lives of shelter dogs. And while we do house dogs in a brick and mortar shelter, I feel we're much bigger than that, with goals of just that, improving the lives of shelter dogs, not just in Ohio, but all across the states. And a really fun job. Get to do lots of innovative things, work with people, work with dogs, speak in lots of different places, including our Practical Veterinary Behavior Symposium. I'm very excited, although, yeah, like Dr. C says, wow, we're all talkers. I don't know how we're going to get through this whole night with your agendas, right? But we're
going to do it. We're going to do it.
It's going to be hard, but it's a goal. Like I'm really excited about it. I think it's going to be fun and to the point, which I think a lot of our attendees are really going to appreciate.
Yeah, me too. And Dr. Gruen, researcher extraordinaire. Tell us about yourself.
Hey, I'm Margaret Gruen. I am an associate professor of behavioral medicine at North Carolina State University, so here in Raleigh. I do teach, I do research. My research focuses a lot on human-animal interaction, sort of broadly, including how animals communicate when they're in pain, how we, their people, notice and interpret that and understand that. I'm also really interested in cognition, and I study the two kind of ends of life, so cognitive development and then cognitive decline. And I'm also really excited to be here and be part of this, and I do hope that you're going to be there with a hook to take us all off when we get to 20 minutes.
She promised me a gong for other people.
Oh, gong. I like a gong.
Yeah, I get to do it, so sorry. Sorry for you guys.
How much did you pay her for that job?
Oh, to get the job?
Yeah, to get
I was gonna say nobody has to pay me for that job.
No.
Do that for free.
I want to be your gong then.
Okay, let's do it together.
Yeah.
I'm in.
I have questions for each of you. You're in the hot seat about your lectures. I'm going to start with you, Chris. You are unofficial communication guru in the Vet Behavior College. You really are. And I'm excited about your lecture. It's called Communication Strategies for Successful Treatment Outcomes. And the thing is, I think that your approach is unique. You know, my experience with clients is that they come with a lot of guilt and shame and judgment from all their neighbors about their pet's behavior and coming to see us. So, do you feel like you see a difference in the communication that you have to have with a behavior client versus when you were in primary care, right? The way you communicated. And if so, how should we be talking to these people that come with this weight on their shoulders?
It's a great question, Lisa. And I think the piece that really stood out for me especially when I was getting started within residency and within the field of behavior is that, if we're talking to somebody about, I don't know, some element of, did you bathe your dog this week, or some sort of more practical element of care, I just didn't feel that my clients put as much sort of value judgments on whether they did or didn't do the thing, or whether they were investing the time in their animal's well-being. There's so much of the emotional, somebody we could say baggage, but it just the weight, the heaviness of that I think we have to be mindful of when we're opening up those conversations. And so I want to make sure that I'm creating a space in which a client is free to share that heaviness if that's what they're feeling. But I also have to be mindful that I'm not projecting that heaviness into a situation where it doesn't exist, right? So I'm not going to come into every situation and say, oh my gosh, this is so hard for you, when the client's like, no, actually, we're doing okay. I just got a couple of questions we need to navigate here. So I think for me, the piece that really ties those together is approaching every client communication with curiosity and kindness and empathy and openness and a lack of judgment in a way that allows me hopefully efficiently to identify where is that client starting from and what does the next step or series of steps forward look like for them, and can I guide them down that path, versus setting an arbitrary, here is where you're starting, here's where you need to end up. This is going to be a path and I'd love to walk it with you if you're open to that.
Yeah, I said to a client the other day, we'd done all the history and been very like, and what happens here and what happens here. And I just looked at her and she just looked so beaten down. And I was like, you know what you're going through sucks. It just sucks. And she started crying and she was like, it really does. And I said, yeah, it does. Like, I just felt like she was able to let go once I acknowledged that I wasn't the big bad doctor that had all the answers in the world and never had lived any of what she was living, right? But that I think it would suck to have a dog with separation anxiety. So I totally hear that.
I think you're spot on. I think so many of our clients come to us just expecting to be judged. They're coming to us like, how many clients have told me, I know you're going to tell me I'm the problem, or I'm here for you to tell me what I'm doing wrong. And it's really just to break down that barrier to say, this is judgment-free zone. We're on your team. We feel for you. And most of us have had a separation anxiety, a fear aggressive dog, dog is not safe around your kids. We've had them all. We've been there and it sucks. We've been through behavioral euthanasia with our own pets in a lot of cases, and we know how much that's terrible and how judgment at that moment is so crushing and debilitating. So I feel like I've had that same experience where people just feel this weight lifted just talking about it, even if we do nothing to change their pet's behavior. Just being a non-judgmental sounding board for them is a great place to start.
Super important. Super important. Margaret, you know that I totally like fangirl you constantly, right? If Margaret's attached to it, it's like the best research I've ever seen, right? So you are, yeah, same, right? You are, in my opinion, our most respected, our most prolific researcher. And I'm excited about your lectures on cognition and on pain as how they relate to behavior problems. They're so relevant right now. So how many, just in your estimation, and you can also pull from the research, of course, but in your clinic, how often do you see patients who you think discomfort and pain are contributing factors or causal factors for their behavior problems?
Yeah, it's such a great question because it's a lot, right? I mean, it's if we look at the data, and a lot of us were part of some data gathering. So if we look at those, like the lowest end of the estimate is like 20%, but the highest is 70 or 80%. I mean, it's a really underestimated contributor to the behavior disorders that we see. And it's pain from all sources. So musculoskeletal pain, sure, but also GI pain or painful dermatologic disease. So lots of things that can be painful. And it makes so much sense, right? Because pain can make us irritable. It can keep us from sleeping well, which can make us irritable, can keep us from eating well or enjoying the things that we used to. And it can even make scary things scarier, right? So if you have sore muscles, or if you have pain and something frightening happens and you tense up, now that frightening thing is not just scary, it is scary and painful. So it's this double whammy. So it can contribute to so many behavior disorders in all sorts of ways.
Yeah, I always tell vets, hunt it down. Hunt it down.
Yeah.
It's out there, So Amy, I gotta say, I always love hearing you speak. You just sound happy and cheerful, and you have a lilt to your voice that I love. So I have a couple questions for you. Because, I grew up at Penn. That's where I had my residency. And we saw 3-hour behavior appointments. And I think the students at Penn probably are practicing now 20 years later and saying, I can't see behavior cases because, it's 3 hours and I don't know what to do. But you don't practice that way. I don't practice that way. I know probably everybody here doesn't practice that way anymore. So can you, give me an idea of what the best way is for a primary care vet to integrate behavior med into their practice with the 15-minute, 10-minute appointment structure? Yeah.
Right. Yeah. I remember those days. Oh my God, the deer in the headlights from me and the clients. Like after 3 hours, you're like, oh my God, I have no idea what's going on, right? I don't even remember my own name. So chunking it down into small, more graspable pieces is kind of how I approach this. And so also utilizing your staff, because as veterinarians, we don't like everything. I hated surgery, right? I didn't want to do it. So if you don't like behavior or you don't know as much as you would like to, use your staff. Someone that you know and love that you probably work with also loves behavior. So they can do intakes where they are going in, getting the history. And even if it's just a quick 5-6 question questionnaire, like Dr. Margaret Duxbury just published in JAVMA recently, and we'll talk about that. Like that's super easy to start screening. And then if you identify a behavior problem, don't try and deal with it at that moment. Maybe give them some quick management tips and then schedule an additional appointment, because it's oh, by the way, as they're going out the door, right? So you need to give it the time that it deserves, but you also don't have to take 3 hours. So chunk it up. Use your staff to your advantage, and then use technology to your advantage too. So we use a transcription service where we are recording all of our appointments, and then it literally produces my soap notes for me. It can produce an email to the client. It's fabulous. So lots of really good options out there.
Yeah, I love technology. Chris and I were just discussing that at VMX, how we use our own different, transcription services and dictation services, but wow, game changer for sure. Megan and I did our residencies together. I was there, I don't know, 1.5 years or 2 years. And then, Mary came first, Dr. Klink first, right? And then you came right after. So we're all Penn at the same time. Megan's always been super practical and pragmatic about the way she practices. And what you did at OSU was pretty fantastic. You integrated behavior. You got under the skin of every other service to the point where they're calling you to sedate their aggressive dog, right? Very antithetical to what people think behaviors are, isn't it? That we sit in our offices and dogs lie on couches and we talk to them about their Freudian dreams, right? Megan's down and dirty doing it. So I'm so glad that you are doing these sedation lectures. So first of all, I talked to a vet today. She didn't think the dog needed drugs. I think the dog needs drugs. How do you determine where to start when you have a patient who can't be handled at the vet's office? Is it injectable? Do you send them with orals? Like, what do you do?
So I think it depends, what do you need to accomplish that day? So you've got to make your priorities of what do I need to do today? What do I have to do today? And where is my patient currently? And I think there are some procedures that we do, surgery, for example, or a procedure where we're going to have sedation, that I just go ahead and recommend oral pre-medications for every patient. We started actually doing that in the shelter environment now, where we know we have days that are going to be extra stressful. So surgery days in shelters, especially if you're doing high volume, high quality spay and neuter, super stressful. So we've just started doing pre-medications for everybody, even if they don't have a history of having fear, anxiety, and stress. I've started talking to more and more groups about this, and I have several groups of surgeons, so referral practices for surgery that do the same thing. They send them, okay, your appointment day is here. Here's your trazodone. You're going to give it the night before and the morning of. And it's not a, oh, we were thinking, we're not sure. It's a, you're giving this just like, as a matter of fact, as you would give a pain medication. And the clients are not balking at it as one might expect. I think it's maybe sometimes we assume our clients aren't going to be game for, we don't want to mention it, or we're worried that they're going to, by giving this pill, it's saying they have a bad dog. And as Chris referred to earlier, it's all about communication. It's meeting people where they are and treating it like medicine. This is a medication to treat an ailment of your pet, or a preventive medicine to prevent the development of fear, anxiety, and stress for this procedure that I can guarantee is going to have at least some modicum of stress for that patient. When
Yeah.
it comes to an approach, your quick answer for patients who can't be handled, I'd say stop handling them so much. And what we'll talk about a lot is the wisdom in less is more for so many of our patients who can't be touched, can't be handled. Well, watch me do it with barely touching them, and you get away with a lot. So
Yeah, I love that. That's the simple answer. Stop doing that. Right?
I know.
Stop doing that. That is good. That's good. So Elise was really my resident mate. She was at Cornell. I was at Penn.
I
But
was
we
slightly
were,
offended that you're calling Megan your resume mate and leaving me out of it, but I didn't want to say anything.
it's
they're
true.
like
It was me and
resident
Elise.
cousins. They're cousins.
Oh, well,
Resident
it was
cousins,
me and
right?
Elise for 2 years on our own, pretty much. We did rounds over the phone because there was no Zoom.
There was
She
no
was at
Zoom.
Cornell. No, oh no. I had my phone on speaker. I was at Penn, and she was really my resident mate, for sure. She was. And the wittiest person I know by far, bar none. So her lectures are going to be funny. I'm just telling you up front. So Elise, you have had personal experience with aggressive cats because your aggressive cat cornered me and bit me when I was at your house. He wasn't very
It was a
good.
failure of
Like,
management on my part.
on my part. He seemed like at that point like 10 stories tall, but he was
Yeah,
like
to be
this
fair, I
big.
told you, I was like, hey, I don't think that you're gonna, I think you're gonna get bitten whether you freeze, move forward, or move backwards. So
So I froze like this. And then he sat on the couch next to me and I was like,
yeah.
I just didn't want to move. But by that time he'd already bitten me and he was over it. I was hanging on to it, but he was over it. So anyway, so dogs and cats, to me at least, present sometimes really differently with aggression toward family members. Do you see that they present differently? What do you think is the same? What's the difference when cats present to you?
I think there's actually some remarkable similarities, and what is different is the people. So people expect different things and allow different things from cats and from dogs. And so what my experience, I'm not saying this is, verified by research, but my experience is that cat families will reach out for help very late because they may have been being targeted with aggressive behaviors for years, months or years. And because cats are cats, and in our culture, the prevailing philosophy is that cats are spicy and sometimes they bite you, right? That unless the problem is very severe, people don't reach out for help, and they also don't know where to reach out for help. Like in Dogland, the information is just overwhelming. It's just an avalanche of information, good and bad. There's rainbows, there's butterflies, there's rocks, there's mud, there's fire, right? Clients can't tell the difference. They're just underneath all of it, right? But in Catland, I mean, it's actually one of the things I love about being a clinician is I love working with aggressive cats. So I love when you gave me this lecture card. I was like, because since the clients aren't so overwhelmed and they don't tend to feel as ashamed and judged because it's just known that cats bite people. So it's not about them, right? That we can start kind of fresher than a lot of clients that have dogs. So cats also, I think, are pretty clear about their signs. And because I'm not saying this is true for everybody, but people don't tend to take it as personally when a cat bites them, because again, in our culture, we just assume cats bite. We don't think of it as like an affront to our power, or they don't love me or anything like that. We're just like, well, cats bite the people they love. That's what they do. So since there are these different understandings, I think it gives us the opportunity to treat in a way that doesn't require quite as much Kleenex in many cases, because there isn't as much baggage for a lot of families. Don't get me wrong, they're seeing us, they're very distressed, and usually their problem is incredibly serious. You know, my cat, my own personal cat, the one you're talking about, I don't know very many families that would have been able to manage him safely. And as you reported from your scenario, actually, even though I was in a behavior residency at the time, I failed to manage him well that day, right? I thought I had that it was okay, and you were experienced and I was experienced, it was fine, right? How many times have we had our clients tell us that, right? Well, yeah, I got it handed to me. And that's when I learned to do protected contact with aggressive cats for every other visitor. So I think there are a lot of differences between cats and dogs and their ethology, their natural species behavior, all that stuff. But what it really comes down to for me is a difference in the clients and therefore the case that they bring into me. It tends to be very serious, but the clients don't tend to be taking it personally, even though they love their animals. Obviously, they're coming in to see a cat psychiatrist, like they're very dedicated to these cats. So they're ready to go forward. And they also have the advantage of not feeling like they have to take their animals out on walks and things like that. So it's not easy for families that are dealing with aggressive cats because the severity can be very, very high. But it is somewhat easier than, say, somebody who owns a Labrador and they live in New York City and they got to go for walks.
Labrador, they're easy. That's why I got them. I wanted slam dunk. I don't want to do any work. That's why I got
This is
one.
like one of your ragey Labradors.
Yeah. But that's what I mean. I mean, just the way that you guys have, in a nutshell, made your point and delivered the essence of what needed to be said. This is the kind of stuff we're going to see at the Practical Behavior Forum. And I'm boarded, and I'm going to sit at every lecture. I'm not going to the
Me too.
bathroom.
I'm excited.
I'm not taking a
Me
break.
too.
I want to see this because I want to know, all right? I want to learn from other people.